Hello, my name is Patty Vassallo. I am one of the clinical non-invasive cardiologists here at Northwestern, coming to you virtual. I want to thank the course directors for inviting me to speak again on ultrasound enhancing agents. I have no disclosures. First, I want to review the physics of ultrasound enhancing agents. In order for ultrasound enhancing agents to opacify the left ventricle, they have to be small enough to get through the pulmonary capillary bed. So the microspheres that make up the ultrasound enhancing agent are smaller than the red blood cell, usually around 1 to 4 microns. This small size allows transmission through the pulmonary capillary bed and allows for left ventricular opacification. In addition, the microspheres are made up of a heavy gas. This heavy gas is a high molecular weight that has low solubility and high persistence and stability that allows for imaging of the left ventricle. As compared to air, which we use for agitated saline, looking at interatrial shunts, air, due to its high solubility, has very low persistence and stability and doesn't allow for persistent imaging. But with these heavier gases, the ultrasound backscatter of the bubbles is exponentially related to the radii of the oscillation. And so if the bubbles start to shrink, there is less opacification. So that is why these ultrasound enhancing agents use the heavier gases. And then when we think about the interaction of ultrasound with the microspheres, remember that the ultrasound enhancing agents are oscillating. And so as you increase power and decrease mechanical index, you get nonlinear resonance. And this allows a difference between the LV cavity and the tissue and enhances the endocardial border. If you continue to increase power and decrease mechanical index, then you actually get bubble disruption. There are 3 FDA-approved ultrasound enhancing agents in the United States. These are Optesan, Definity, and Lumasan. They all have a heavy gas, but Optesan and Definity use perfluoropropane, while Lumasan uses sulfur hexafluoride. In addition, they all have a thin shell. Optesan has a human albumin-based shell, while Definity and Lumasan have a lipid-based shell. This again allows for slower diffusion of the bubbles and allows for left ventricular opacification, which is the only FDA-approved indication for cardiovascular disease. Optesan and Lumasan are both hand agitated, while Definity requires a vial mix device. How do we optimize imaging with ultrasound enhancing agents? Well, most of the vendors will have a contrast preset, and you want to have a good echo contrast preset. However, we have to optimize the image. So let's go through some practical applications. The image on the left shows echo contrast without harmonics. What you really need to do is you need to image with harmonics with a very low mechanical index, and this improves the endocardial border definition. How would you improve this image? Well, what do you see? You see that there's swirling, but you also see that the left ventricle looks like it has normal function. And so what you see in the right upper corner is a mechanical index. The mechanical index is too high. You want to use a mechanical index of 0.1 to 0.3 to prevent bubble disruption and allow for persistence and imaging of left ventricular opacification. You can also get swirling if you have a large, or if you have a dilated left ventricle, and sometimes you need to increase the amount of contrast used in patients with a dilated left ventricle. Well, what is wrong here? Well, what's wrong here is that you don't see the basal segments. So this is incorrect focal zone placement. You really want to have the focal zone placed closer to the mitral valve to allow for better visualization of the basal segments and the left ventricular apex. How would you improve this image? Well, this image, you see the left ventricle and you see the ultrasound enhancing agent, but the ventricle is very far away and we want to see the left ventricle. And so this is just incorrect depth. So you want to decrease the depth here so that we can focus on the left ventricle. Why is this image so gray? Well, remember your dynamic range. So this dynamic range is too high. So you want to adjust the dynamic range to delineate the borders. And so keep your dynamic range lower. This obvious problem is, and we can have participation, but yes, this is overall gain is too high. So let's put it all together. To optimize contrast, echo contrast, one is you want to make sure that you label the view because it's often hard in echo contrast to see what image you're looking at. So always label the view. You want a mechanical index between 0.1 and 0.3 when you're imaging for left ventricular opacification. You want your focal zone to be at the mitral valve level. And you want to make sure that you are zoomed onto the left ventricle. Remember that the preset is only a starting point. Every patient is different. You can adjust the gain and TGCs if needed. If the apex is too bright, remember to decrease TGCs. And remember that 2D receiver gain and TGCs have no effect on bubble destruction. So let's start with a case. This is a 56-year-old male with hypertension who presents with new onset heart failure, elevated BNP, and negative troponin. What you see here is you see that that there is severe LV dysfunction. You also are concerned about increased trabeculation in the apex, and the concern is this a prominent papillary muscle, or is there concern for LV non-compaction or other abnormalities in the left ventricular apex? When you don't see the apex well, or you have decreased LV systolic function, or you're concerned about regional wall motion abnormalities, you need to use ultrasound enhancing agents. Here is the apical 2 chamber. And what you see here is foreshortening. Whenever you see a rounded LV apex, you know that you have foreshortening. And giving contrast can help to prevent foreshortening and make sure that you're not missing the apex. So when we're evaluating thrombus, which is a common indication for ultrasound enhancing agent, this study by Kurt et al. Looked at what the reader thought before contrast and after contrast. You can see that there was a high suspicion for thrombus in 35 patients before contrast, and 2 were deemed definite thrombus. However, after contrast, you see that only 1 of the suspected thrombus was actually real, and there were 0, the definite thrombus was actually not present. This will really change your management and will also prevent downstream testing. The other interesting finding was that ultrasound enhancing agent picked up 5 thrombus that were not suspected. So again, showing that we need to use ultrasound enhancing agents to improve our diagnostic echocardiograms and make sure that we are not missing apical abnormalities. So in this patient, back to this patient of concern for the increased trabeculation, you see now that this is a papillary muscle and that there is good opacification of the left ventricle, except for this echo-free zone, which is consistent with LV thrombus. The apical 2 chamber view is still technically difficult, but you see that it is less rounded. And again, you see that there is thrombus in the apical inferior segment. The next case is a 27-year-old female who presents with increasing dyspnea exertion and palpitations. Her laboratory evaluation showed an elevated BNP and a minimally elevated troponin. As you can see from this image, it's a very technically difficult image, and you may be able to tell that the LV systolic function looks reduced, but it would be difficult to assess regional wall motion abnormalities, evaluate for thrombus or other apical abnormalities, or tell me what the ejection fraction is. Here's the 2-chamber view, which again is very technically challenging. Now, when looking at the echo enhanced image, you can see that there is concern for increased trabeculation as well as a filling defect in the apex, consistent with thrombus. On the apical 2-chamber, I think you can appreciate the increased trabeculation a little bit more, and you again see the apical filling defect. Indications for echo-enhancing agents in non-compaction cardiomyopathy. This is important to remember that you should use intermediate harmonics with an MI of 0.3 to 0.5, which will more clearly distinguish the trabeculations. The ratio of non-compacted to compacted ratio of greater than 2:1 meets criteria. This patient went on to cardiac MR and had a diagnosis of LV non-compaction. How about intracardiac masses? How can UEAs help with intracardiac masses? Well, if you use very low MI, you can see whether there is any opacification of the fixed defect. So here you see with thrombus, which is avascular, that you don't see any ultrasound enhancing agent within the mass. However, with myxoma, you do see that there is some echo contrast within the mass. And then with metastatic tumor, you see that there is even more echo contrast within the mass. And this shows that there's increased vascularity. So that can help to delineate intracardiac masses. The other important indication for ultrasound enhancing agents is when you need better quantification of left ventricular volumes. So this is useful in cardiomyopathies and valvular evaluation, especially in patients where you're following for aortic or mitral regurgitation, and the left ventricular volume will change management. So don't forget to order your echocardiograms with ultrasound enhancing agents to better predict what the left ventricular volume is. In addition, we know that contrast echocardiograms compare more favorably with cardiac MR. And then another important indication for ultrasound enhancing agents is when you're evaluating regional wall motion abnormalities, both at rest and for stress testing. If you cannot evaluate the coronary artery distribution with 2 contiguous segments, then you need to use ultrasound enhancing agents. And this will help improve your diagnostic capabilities. And enhancing Doppler signals. This is an important indication, and I always make sure to remind the sonographers that if you are imaging for left ventricular opacification and you didn't have an adequate tricuspid regurgitant jet, or you're looking at someone with severe aortic stenosis and they don't have a good aortic valve measurement, you can go back after you use contrast for the left ventricular opacification and then look at Doppler. But remember that this can also cause abnormalities in the measurement if you don't allow for some of the contrast to dissipate. So here's an example of someone who had an unenhanced image and had a TRV max of 2.8 meters per second. And when they went back to use contrast, it was actually reported to be a TRV max of 3.9 meters per second. And the patient was given a diagnosis of moderate to severe pulmonary hypertension. However, you really want to take this signal from the most dense Doppler signal. And the TRV max is more compatible with 2.9 meters per second. And so this patient went on for right heart catheterization and did not have moderate to severe pulmonary hypertension. So make sure you're using this, but you avoid the feathering artifact. So the importance of UEAs in clinical practice is that up to 20% of unenhanced resting echoes are non-diagnostic, and up to 1/3 of our unenhanced stress echoes are non-diagnostic without ultrasound enhancing agents. This number is only increasing due to increased bedside imaging, complexity of patients, obesity, and lung disease. So we really need to use ultrasound enhancing agents to improve echoes, improve our diagnostic ability, and decrease downstream testing. In that study by Kurt et al., uninterpretable studies decreased from about 12% to almost 0%. And technically difficult studies also significantly decreased with ultrasound enhancing agents. So we see this in critically ill patients in the ICU when we cannot tell what their LV systolic function is. And then we use enhanced echo, and it may be the only thing we see, but usually we can tell whether the ventricle is functioning normally, hyperdynamic, or the LV is dilated with reduced function. And that makes a big difference in our critically ill patients. The last case is a case of a 53-year-old male transferred. He had a history of MI and cardiogenic shock. His echo shows that he has a pericardial effusion and almost looks like normal LV function on his peristernal view. But on the short axis, you see a large echo-free space in the short axis view. Here it is zoomed up where you see actual ventricular rupture, and it's a contained rupture with a small pericardial effusion. Here is the apical 2-chamber view, and you see a large pseudoaneurysm there. Here we use color Doppler, which is often referred to as the cheap man's contrast echo, but you can see that the color Doppler, although it's set at a low signal, you don't get opacification of the entire aneurysm. And so it's unclear if there's thrombus there, but after evaluation with echo enhancing agent, you see that there is no thrombus, and this patient was emergently taken for surgery and had a good outcome. Finally, the American Society of Echo has a contrast zone. And so I encourage everyone to belong to the American Society of Echo, and they have excellent guidelines with contrast and excellent cases. They also speak to frequently asked questions and troubleshooting. So it's a great resource. Finally, ultrasound enhancing agents are safe, they improve image quality, and result in more diagnostic echocardiograms. It's important to troubleshoot settings and optimize administration of UEAs in your lab to improve image quality. And finally, ultrasound enhancing agents are really important in the critical care setting and in patients with pulmonary disease and obesity. I appreciate your time, and I hope that everyone stays safe and hope to see you next year in person.